Okay, so Dr. Golia was diligent in putting together these slides, which I looked over and edited a bit, but we're going to go through intracranial abscesses and empyema. And so to classify them, there are various forms of intracranial separation, what we call a classic brain abscess, which is sort of an intraparenchymal process, a subdural empyema, and an epidural abscess or empyema. So the epidurals are usually slow-growing, rounded, and tend to be localized. A subdural represents pus between the dura and the arachnoid, usually unilateral, but they can spread more rapidly, although they are limited by some of the boundaries within the brain. These usually spread by direct extension from some contiguous focus of infection. People asked about head trauma. They can certainly occur after head trauma or after neurosurgical procedures, but often they arise from infections inside the head, whether it's in the sinuses, in the middle ear, dental infections, as was mentioned, mastoiditis. In young children, they sometimes occur as a complication of meningitis. So if you see suddenly an enlarging head circumference or mass effect causing symptoms, you want to think about doing imaging to look for a subdural empyema. The organisms that cause these tend to depend on what was the source. So, kids that have congenital heart disease, for example, that might have right to left shunting, you can often see a variety of organisms that may include things that may get into the blood, organisms from the GI tract, like gram-negative bacilli or anaerobes. But most of the time we see these from the paranasal sinuses or other sinuses. And so we think about the organisms that are inhabitants of the oropharynx. So lots of anaerobic streptococci and other anaerobes. And so very importantly are the anginosus group, the viridin streptococci, which include things like strep anginosus, Streptococcus intermedius, and others. Other organisms can also cause these infections, so you really want to take a good history and find out what other potential exposures people have had. So we have to consider AFB and fungal infections. And with surgery, you think about Staph aureus, anaerobes that may exist in the skin. Despite efforts to sterilize the skin, sometimes these organisms can get inside. There can be spread from an osteomyelitis of the skull, fetal monitoring probes, and other organisms. And of course, in immunocompromised patients, the variety of organisms is even greater.
Dr. John, I'm not sure we're seeing the slides. We're not quite following along with you. We're still just seeing the PowerPoint just window. We're not seeing the full screen.
Oh.
So you may have to go back to Zoom and then share screen again with the full screen there. Okay.
Okay.
We're seeing epidemiology now.
Okay, now you see. Okay, so maybe when I went to
Dr. Dijon, it might be best, since we can't see the PowerPoint, if we just go ahead and have you make comments on the case, because then we have the monkeypox presentation and we can do a further talk another time with all the PowerPoint slides.
Okay, there's not many. I just want to go over a couple of quick things. That it's a relative, you can see them now, right? I'll just leave it up as this.
We're seeing epidemiology, yeah.
But you're not seeing the rest of the slide?
No.
Oh, wow. Okay.
So we'll just have you, if you can just close out, just have some comments on the case, and then we can dive deeper on the topic a little bit later.
Okay, all right. So one of the things I wanted to point out is that there was a CDC advisory about these kinds of infections in children. There were 3 cases reported from California earlier this summer. And so an advisory was put out. There were 3 cases of Streptococcus intermedius brain abscesses in kids that had had underlying sinusitis. And so the CDC has put out a call for other cases. And I can tell you that in our area, I mean, I've seen about 10 to 12 of these in the past year at least. Oftentimes, there are other presentations like periorbital cellulitis or orbital cellulitis or a Pott's puffy tumor. And the organisms that were growing out by and large are in this viridin streptococcus group, sometimes Staph aureus. So we're seeing more than I think I've seen in years past. And we've wondered about what some of the reasons behind this may be. You know, we're talking about global warming. Are there more things in the air, in the environment? We've had a lot of very, very windy days. The other thing that we've seen a lot of, including a subdural empyema, was coccidioides immitis infections. And we had a girl with a subdural empyema that was cocci. And we've seen other really severe cases of disseminated cocci. That's a little bit unusual in the high desert, seen more in Arizona and parts of California, but I'm just wondering if these may be somehow related. Diagnostically, imaging really is the methodology of choice. MRI, with contrast, even better than CT, but both can be used. And then the treatment is combination of surgical and medical. So you need surgical intervention to drain abscesses, to put in drains, to consider shunts, but you also need broad medical coverage with antibiotics that cover the common organisms that include basically staph, strep, and anaerobes, sometimes gram-negatives. So drugs like vancomycin, appropriate cephalosporins, and metronidazole are the treatments of choice. There are lots of potential complications. Most of the time nowadays, mortality has been greatly reduced because of advances in diagnosis and surgical methods. And most kids now survive, and most actually recover without sequelae, although probably a good 25 to 30% will have some neurologic or other sequelae as a result of these infections. I'll leave it at that so we can move on, but sorry about the glitch with the slides.
Thank you, Dr. Dijon. I'm just going to ask quickly from anybody else on the hub team, do you have any recommendations for this case in specifics to the questions, or if you have any additional comments, and then we can move into Dr. Medina's didactic today.
I just wanted to say thank you for sharing that fascinating case, Dr. Dijon. And is there a role for repeat imaging at the end of treatment, given his fairly recent recurrence after medical therapy?
Absolutely. You're anticipating some of the stuff that was on some of the excellent slides that Dr. Golia put together. But yes, actually, repeat imaging, you certainly want to do to see that you're getting resolution of the lesions. It may take a while, but you need to, down the road, repeat the imaging.
Thank you.
Okay. Anything additional? All right, Dr. Medina, with that, we can turn it over to you. I do have your slides up if you're having problems with sharing today. Just let me know what helps you.
Let's see. Hold on a second. Let's try this. See how I fare.
Great.
You guys see my screen?
We can. You could put it in.
And presentation mode?
Yes, sir.
Let's see here. All right. So you went over this already. I'll jump to my slides. Okay, I did a little bit of tweak here. We're going to speak on monkeypox today. The title was New Disease Threat ? But now we know that the WHO has officially named this as a global disease threat. And there was some contention on that, but I think Dr. Ghebreyesus, the head of the WHO, is right on the money. So with that, we'll move over to the learning objectives. We're going to talk about what monkeypox is, what the traditional presentation looks like. We'll touch on the novel clinical presentation and epidemiologic factors of the current outbreak, its journey through the world, chronicles of unlearned lessons. What about the United States? What about the state of Nevada? Clinical guidance. We'll touch briefly on clinical suspicion, diagnosis, isolation, treatment in special populations, and then finish off with vaccines. This is really important for me to say ahead, as in the early stages of COVID-19, the emergent data on the monkeypox outbreak is arriving at breakneck speed. And so every single day there's new developments. So we'll touch briefly on what I thought was important in a narrative form to keep you guys entertained a little bit too. So a little bit of learning, a little bit of entertainment. And we'll only, innumerable issues can be debated, but the supporting evidence is lacking. So we'll keep it a little bit superficial today. So about monkeypox. We're having a monkeypox outbreak in 2022. First case was reported in the US in 2021. It's a rare disease caused by an infection with a monkeypox virus. It is part of the Poxviridae family, which causes variola. Symptoms are similar to smallpox, but milder, and luckily it's rarely fatal. Depends on which clade of the virus you're talking about, but the one we have is a lesser fatal virus. It is not related to chickenpox, that should also be noted. So it was discovered in 1958 when 2 outbreaks of a pox-like disease occurred in colonies of monkeys kept for research, and hence that's why it was called monkeypox. But monkeys are not the natural reservoir. The origin of the virus remains unknown, but African rodents and non-human primates like monkeys might harbor the virus and infect people when they are in close contact. And what that means usually is that people hunt monkeys for meat, and so the so-called bush meat. And when they're sacrificing the animals, they're in contact with the pathogen, and that's how they get infected. So this is some images from Medscape. And on the left-hand side, you see the traditional lesions of monkeypox. On the right-hand side, you have an electron microscopy image of the virions there. And you can see that it is really not a subtle disease. It causes significant disease burden in patients. And on the physical exam, it's important to look at lymphadenopathy as a distinguishing feature in the clinical presentation of the disease. You can look at the lesions and think of smallpox, but usually smallpox doesn't have lymphadenopathy. And you can have swollen lymph nodes in the head and neck, the armpits, the groin, etc. This is an image on the left of healthcare workers in Africa on full PPE garb. And then on the right, a patient that has healed from the disease, and you can see that you have many scars left over from it. Mortality and complications. So in the United States, we haven't had any deaths, and there have been a few deaths in the current outbreak internationally. In Africa, it's reported to have a mortality between 1% and 10.6%, with high-risk individuals like those that are immunocompromised having worse outcomes. And one of the complications that you can see is secondary bacterial infections on the wounds. Now, these 2 images here are representative of lesions of monkeypox in different stages of evolution. On the right-hand side, I want to make a comment that this disease can also be confused with other sexually transmitted diseases like syphilis. And so the degree of suspicion in the context of the outbreak should be top of mind for clinicians. And on the left side, you see these lesions that appear pustular, essentially. And we'll show more pictures of the evolution in the slides coming up ahead. So the world has seen now this disease outside of the endemic areas, which was in Africa. You can see on the left-hand side here, the map where Europe has the highest concentration of cases. But just today, I was reading that the United States now is actually leading the case count, certainly in America. And the CDC did have a travel alert warning level 2, which was to practice enhanced precautions, which essentially wear a mask through traveling. There was controversy with that, but we'll leave it at that. It is not an airborne disease right now. There is a possibility of droplet transmission. And so here you see some photos from the UK Health Security Agency where you see the evolution of the lesions. It usually starts with an area of redness or erythema, and then you develop a small nodule that turns into a pimple-like lesion, then a vesicle, then a pustule. You can see here on the top right-hand corner that there's an area of umbilication there, meaning a little dip in the center of the lesion, which can make you confused with other diseases like that which comes from molluscum contagiosum. But usually you have widespread lesions. Now in this outbreak, it's different because you don't have the classic presentation with lesions all over the place. You have much more spare disease cropping, and that could confuse some people. And then as time goes by, those lesions crust over until eventually the scab falls off and you have clean skin underneath. This is just a visual representation of cases in the United States. This is from CDC from late June to mid-July. And at the last time I checked, we were at 2,100 cases. I'm sure that's higher now. So we're going to take you on a journey through publications from healthcare magazines, Becker's Hospital Review, CDC publications, just to kind of take you around how difficult it has been. So right now, CDC is trying to alert clinicians and people about what monkeypox looks like. And essentially, it starts with an influenza-like illness, fever, headache, muscle aches, kind of like what you get with COVID. But in the 5 days after exposure, you can start having a rash and swollen lymph nodes. Now, it's important to mention that it is not an airborne transmission disease like COVID is, but you can get it through droplets. And also that there's other symptoms that are not traditionally present in the standard presentation of monkeypox, namely genital lesions. Now, with what we've learned from COVID, we're trying to take hints from that playbook, and the Biden administration is working on that vaccination strategy to prevent the spread of the outbreak, but it's been met with significant difficulties. There's an emergency operations center to combat monkeypox. There's going to be now a monkeypox czar, so to speak, just like they did with COVID. Some of the usual people are being considered, but they haven't decided yet, either Dr. Fauci or Dr. Jha, to hopefully rein in all the resources to prevent this from spreading. But it's very, very difficult because of the logistics that it takes. New York is bearing the burden of the current outbreak, and it's the state that has the most cases thus far in the United States. This image here I wanted to show because you're trying to hit that nail with the hammer, and despite your best intentions, you'll have different outcomes until you finally get it right. The IDSA here is working really diligently with providers that do ID in acquiring knowledge of real world experiences. And TPOXX, which is the medication that we're using to treat, it's approved for monkeypox in the United States, but it's not designed that way. And so it's essentially what's for smallpox, we're using it for monkeypox. And the IDSA as a society, we're reaching out to our members so that we have more real world experience. So the entire ID society is collaborating. MMWR is a publication of CDC, the Morbidity and Mortality Weekly Report. You see that in early July, that's only 3 weeks ago, the cases, the percentage of specimens tested was higher at 64%, and then it's kind of evened out about 50%. Testing is a big issue because it's not widely available. Right now, our health department in Nevada is able to provide testing, and I think also LabCorp in Nevada is also doing the testing. The turnaround is about 24 hours, if I recall correctly, and testing is critical to diagnosing the disease and then starting treatment. Several states, again, are having very high difficulty in securing vaccine doses, and then with the logistics of having the appointments to deliver those vaccine doses to vulnerable individuals. And you can see that in San Francisco, people just flock to their health departments to get the vaccine, and they quickly run out, and it's impossible for them to get that protection. So the US government continues to order vaccine from the manufacturers, Bavarian and Nordic, as much as they can. The CDC has done an inspection of the facilities with the FDA and has approved more production and purchasing more doses. But they're not coming here fast enough, so the supply is definitely not meeting the demand. I highlighted this in red because there's a paper recently that showed that viral DNA was detected for monkeypox in semen, saliva, urine, and feces. Now, this is not traditionally a sexually transmitted disease, but it's certainly behaving like one. We also have to mention that just because you find DNA in these bodily fluids doesn't mean that it contains replication-competent virus, i.e. infectious virus. But I think the level of suspicion should be high until more data is available, and we should counsel people to avoid exposures or risks as much as they can. Moving on to talk about the barriers of treatment and vaccines is the accessibility of these drugs. So TPOXX, again, is the tecovirimat, the drug that we're trying to use to treat. You must confirm the diagnosis. You must request this from CDC through a specialized process that really has a lot of paperwork involved. So much so that sometimes it takes 3 days for the drug to reach the patient. And CDC is working diligently with the health departments in each state to streamline this process so that the drug can be more available in a timely fashion and that clinicians don't have to bear that burden of excessive paperwork. So again, more vaccine is coming. The CDC director warns that monkeypox outbreak will likely grow in the coming weeks. We know with our experience from COVID that the reported number of cases is a significant undercount from the actual number of cases, but the testing mechanisms are not there yet. So as those get better, we will see an exponential rise in the reported number of cases. This is a clip from Southern Nevada Health District Public Health Advisory from November of last year when they talk about that imported case of monkeypox in Maryland. And only a few months later, we have a significant burden of the disease and the outbreak worldwide. This bottom clip is from July of 13 of this month, of this year, and 6 cases were reported. I think we're past 11 now. Most of them are in men who have sex with men in their 20s through their 50s, and no cases have been related to one another. We'll briefly touch on clinical guidance, looking at clinical recognition, monitoring persons exposed, how long to isolate people, what to do with pregnant patients, what options are available for treatment, and then specifically tecovirimat. So after you've been exposed with a patient that has monkeypox, an incubation period usually follows, which lasts about 1 to 2 weeks. During that time, people feel otherwise fine, and they're not generally considered to be contagious. That is then followed by the prodrome, which is essentially a period of time where people start to have mild symptoms. They can be contagious during this period, but the most highly contagious stage is when you have lesions throughout the body. But you could have fever, malaise, headache, again, sore throat and cough, which you could confuse with COVID, that clinical syndrome. That's why testing for COVID is important to rule that out. And then lymphadenopathy is a distinguishing feature from monkeypox when compared with smallpox. Once these lesions appear, the rash appears, you're considered to be infectious. And then follows that formal rash period. Now the rash period will last for different days in different people depending on their immune status and the burden of disease. So that complicates things in the context of isolation, which we will talk in the next slide. So how do you monitor people that have been exposed? Well, there's about a 21-day period from their last exposure that we worry about, in which they can develop symptoms. And what you're looking for is the development of fever and chills, lymphadenopathy, and a new skin rash. What the guidance is saying is that if after 5 days of the onset of symptoms you don't develop a rash, it is highly unlikely that you have been infected with monkeypox. And just for operational purposes, we'll leave it at that. So monitoring for healthcare professionals specifically. So if you're a healthcare worker who's caring for a patient with monkeypox, you should be alert of your symptoms within those 21 days. But if you don't have any symptoms, you can actually keep coming to work. Again, exposure is when you have come in contact with a patient that has the disease, but you have not been wearing proper personal protective equipment. This is why we must remain vigilant and diligent in always using the right PPE in patients that are suspected to have an infectious disease. So if you've been in direct or indirect contact and you're worried about potentially being exposed, talk to your infection control and infection prevention service in the hospital. At UMC, we're lucky to have several infectious disease physicians that can help, and then we can tell you whether or not you need prophylaxis or just monitoring. So be in close contact with that team. The duration of isolation procedures for those patients that have monkeypox infection depends on how long the lesions last. If the patient comes into the hospital for pain control, which is probably one of the biggest issues right now, unrelenting fevers, etc., you keep them in the hospital and you treat them. But if they get better, it's not necessary for you to keep them in the hospital until those lesions resolve. If they have an environment at home where they can recover, you can send them home. They can continue the isolation period at home until all those lesions have been resolved. It is important to always be in contact with the health department so that they're in the know and they can supplement the recommendations from your ID physicians and infection control team. Again, isolation must be continued until all lesions have resolved. If most lesions have resolved, but some have not, they're still considered to be infectious. Other considerations is PPE. What does that look like before entering a patient's room with monkeypox? You're to wear a gown, gloves, eye protection, like goggles that cover your eyes and the side of the face, or a face shield, and an N95 respirator. Now, we did say before that this is not an airborne pathogen, but this is the current recommendation from CDC. Now, if you are doing an aerosolizing procedure on that patient, so much more is important for you to wear an N95 respirator. Now, just briefly to touch on people who are pregnant or breastfeeding, it is a huge area of concern. Again, none of the treatments are authorized for this, but you have to do something in those vulnerable populations. So you either give them TPOXX or offer them immunoglobulin, but there's not a lot of experience with that. So because there's so much gray area, we won't focus so much on that and to finish the presentation on time. So there's treatment information for healthcare professionals. There are interim clinical guidance available for clinicians. Most people that have monkeypox have a mild self-limited disease and they do fairly well. But those that are experiencing tremendous pain or that are immunocompromised, the consensus is that we should offer them something. And so the options that are out there are limited. You can use immune globulin, vaccine immune globulin, but it's not readily available and not recommended for everyone. Cidofovir is an antiviral that should have some activity against monkeypox, but there's, again, not an indication for this, and there's not a lot of robust data supporting its use. And brincidofovir has also been commented on as a potential agent to use, but there's, again, not supporting evidence that this is the right thing to do. And it's also under the same special access program that has a lot of paperwork. I've used it before and it's tremendously difficult. So really our options are tecovirimat, also known as TPOXX, which is an antiviral agent. It's obtained through the CDC. There's a huge amount of paperwork and follow through and post-treatment assessments that must be sent to CDC in order to use it. But CDC and local health departments are working on ways to streamline this so that people can have rapid access to the drug. And, I'm not going to go through that text. The other option is to have vaccination against monkeypox. And there's really two options, and one of them is the preferred. So the Jynneos vaccine is also known as Imvamune or Imvanex, and that's the preferred vaccine to use. And the alternative is the ACAM 2000. The difference between these two products are that the Jynneos is a non-replication competent virus, which is the preferred, and the ACAM is a replication competent virus. And so that could have more side effects. If the Jynneos is not available, then ACAM 2000 is the second one to consider. If you receive ACAM 2000, you are considered to be immune 4 weeks after your dose. And if you receive Jynneos, you're considered fully vaccinated 2 weeks after your second dose. And I think they're 28 days apart. The trouble is that even though Jynneos is approved for monkeypox in the United States, there's, again, no real world data. And we're just hoping that it turns out to be effective in the real world. And I want to close with this paper that was published last week in the New England Journal of Medicine, which is a beautiful capitulation of the current outbreak of monkeypox in the world. And it's important to go through it if you have a chance, because it is a wonderful review of the disease in general. It talks about the epidemiologic findings of the current outbreak, how the epidemiology of it has changed from the original presentation in Africa. This is mostly a disease that has been seen in people, in men who have sex with men, overwhelmingly in the United States and throughout the world. It's affecting people of white race. That's 75% of cases are in people of white race. 41% of patients have HIV co-infection. So it helps you get a real world picture of what that outbreak looks like in the modern day, this current outbreak. It helps you look at treatments available for it. Again, tecovirimat and vaccination post-exposure in the early stages of disease is what we're all trying to do. And it offers a call to action for not just the medical community to increase the knowledge of the disease and identifying the disease, but also to help the public health departments in streamlining those diagnostic tools and treatment tools to make it move forward more smoothly. So very, very good study to look at. I recommend it highly to all of you. And we'll just end with the recap slide. We talked about what the disease is, the traditional presentation, the novel clinical presentation of this outbreak, what is happening throughout the world, how unfortunately we haven't learned the lessons from the COVID pandemic to apply in the current outbreak of monkeypox. The United States has seen an increasing burden of the disease as compared to other countries. In the state of Nevada, we have the ability to diagnose and treat. We should all support our public health authorities to do a better job. We know how to suspect it. We know how to diagnose it. We know what to do in terms of isolation and treatment. And hopefully vaccines will come in greater numbers, and the logistics will help us take care of patients properly. So I'm going to leave it at that with 5 minutes to spare to see if there's any questions that I can help answer. And how do I stop sharing? Stop sharing.
There we go. We do have one in chat from Dr. Bian. It's a clarification on resolved lesions. Scabbed lesions is still infectious then?
That's correct. That's correct. So even though the lesion is dry, if you still have a scab attached on it and there's not a complete repaving of the skin underneath the scab, they're still considered infectious. Now it's the atypical, because the next part of the question is the largely atypical presentations is usually this is a rash that starts with an enanthem, meaning some mouth lesions, and then you start having face lesions, and then it goes centrifugal, meaning away from the body. And in these presentations, you're looking mostly at lesions that appear at the site of contact. So you're seeing a lot of lesions in the mouth because of oral sex practices. You're seeing a lot of lesions in the genitals, which is where the inoculation of the virions happened. You're seeing urethritis, you're seeing proctitis. Some people are having meningitis, myocarditis. So the classic presentation of monkeypox is not what's happening here. This is a pathogen that is quickly evolving and causing a different disease than what we were traditionally privy to. And so it's evolving. This is why this New England Journal of Medicine paper was so important to look at, because it gives you that. If you go look at Mendel's and you look at monkeypox, that's not what's happening here. And so this paper gives you a better idea of the current picture of what's happening, and will probably give you some insight as to where it's going to go. Now you're seeing cases outside of those risk groups, men who have sex with men. You're seeing now children that have had the disease probably through fomites, meaning an adult that has the disease, and then the kid jumps into the bed and sleeps there for the night, and then it's in contact with these virions that have shed from the lesions. And so there's pregnant patients now that have had monkeypox in the United States. Nobody's died yet. And so we got to keep up the speed with what happens and hopefully react accordingly. Variola vaccine and a booster in 1982. it is possible that the immunity has decreased, but you probably should be okay. Next up is I can provide some information. Thank you for that. Please jump in.
Hi, it's Denise Stokich with Division of Public and Behavioral Health. I put a link to a very helpful presentation. It was done by CDC and IDSA on Saturday. It's 90 minutes. It's well worth your time. If you have time for that, provides a great overview as well. That would be a good adjunct to the presentation today. In terms of treatment, we are ordering medication, the TPOXX, to be pre-positioned throughout the state. Some sites have already received that, so it will be pre-positioned in Clark County, Washoe County, Carson City, and Elko. And the CDC has also streamlined the process for accessing and using treatment. So you no longer have to have a clinical consult unless you would like one. You can certainly have that. You would be working through a facility, not individually. So your facility would be completing the paperwork, and then you would be ordering it through that process. I tried to post a slide that has helpful information that kind of explains, the things that are necessary and then the pieces that are optional, but it won't let me. So maybe I can send that to the Project Echo folks so they can share that with the group.
And thank you for that, Denise. One of the biggest challenges I had with this talk is the immense amount of information. How do you put that in a 20-minute soundbite, essentially?
Exactly.
And I know that even though the process is being streamlined, you still have to do it. It's just you get the drug first, and then you send the rest of the paperwork.
Right. The amount of visits has been decreased. The amount of paperwork has been decreased. And the reason for that is that it's sort of under the CDC's.
Maybe.
Yeah. And so there is a bit of a process, but again, much more streamlined than originally. And then the document that your pharmacy would be reviewing to figure out what they need to do has been reduced in size as well.
But I agree. Thank you for that link. Those COCA calls are definitely worthwhile.
And then for laboratories, LabCorp and Quest both have testing. And because they send the specimen out of state for the test, the turnaround time can be, up to 3 days. The state lab in the north and the public health lab with Southern Nevada Health District, they also do testing, but they have to, you kind of have to be screened. So you'd reach out to your local health authority if you want to test through those laboratories.
Thank you.
We do have one more ask in chat from Valerie. She says, how long does it last on surfaces?
I have not seen that data yet, to be honest. But the infection control recommendations are very similar to COVID. So don't touch anything with your bare hands. If you're taking care of the linens of that patient, use gloves, use PPE essentially, use Q-list disinfecting agents. So essentially what you use for COVID, the same precautions are there for patients. If the recommendation is that they isolate alone, that they have their own dedicated bathroom, just like we do for COVID, sometimes that's not possible. But that's kind of where we're at with that. That's funny, Dave.
Oh my goodness. Denise, did you want to mention, is that an article about?
Sorry, I just put the link to the LabCorp test and then the Nevada State Public Health Lab test. For some reason, I can't get the Quest Diagnostics test menu to work. So if I can get that to come up, I'll post that as well.
Great, thank you. And then Dr. Wadi, a child can get TPOXX testing on fluid from lesion?
So TPOXX is the drug, right? That's the drug tecovirimat for treatment. I think it was limited to children 12 and over. I'm not quite sure, but it's mostly for adults. And again, I'm an adult ID doc, so I'll have David jump in there if he knows what the answer to that is.
Sorry, repeat the question, because I was on a phone call, sorry.
If TPOXX is authorized in pediatric patients,
If that, I don't know the answer to that. I can try to look it up, but this is new stuff. I'm not aware of it.
And this is Denise. I believe with the vaccine, it's licensed for 18 and over. I believe TPOXX can go to a patient as, I think the weight is 3 kilograms or greater, so it can be used with infants and children. And I can send more information to Project Echo if that would be helpful.
Thank you for that. And it comes in oral formulation and IV formulation.
And they do have instructions for crushing the oral formulation if it needs to be given through an NG tube or to a child.
Perfect. Thank you.
And then also we'd like just quickly mention, we do have the slides that we put in the box resource folder, which I'll talk about in a moment, but I will also link the resources from Denise and her team and put them in the folder also, so they will be available.
I hope that was helpful for all. It was really tough to, pack in so much information in 20 minutes.